the most effective way to motivate health professionals to do the right thing is fear. Do we believe that patients are best motivated to follow treatment plans by fear? Could there be a different way? Fear, an emotion, an experience, very familiar to every human on this planet, isn't it? Healthcare workers, we live to soothe fear. It's what we do every day. It's a huge part of our jobs. But we ourselves are not immune to it. And I want to have a very frank discussion with you about what is fear doing in our healthcare systems and how is it affecting us. I can still remember vividly the patient encounter that I had in which I think I can say I was the most scared I've ever been. I was just a first year attending my first job, working in the Indian Health Service in a very rural central hospital. And I encountered a patient that I worked very hard to care for. And it was very scary. It was one of the scariest moments of my life. And it almost ended my career. I was on call. And this mother came in 35 weeks pregnant. In the late evening, she was pregnant with her 7th child. She had 7 kids, all under the age of 9, and she'd had 6 prior C-sections. She came in with complaints of headache and swelling and overall not feeling well. And as we began to evaluate her, we found that her blood pressure was very high and that her labs seemed to show that she was developing severe preeclampsia, a complication of pregnancy that can be, if not treated, life-threatening to mother and baby. And she needed to be delivered. That is the cure for preeclampsia, and I knew it. And as I looked through her chart, I realized, wow, all the providers who've seen her up to this moment, they've worked so hard to try to reduce risk for this woman. But this woman and her husband had made the choice not to prevent future pregnancies after each C-section. And every provider had counseled them on the risks of too many C-sections. Very risky. You can have risk of hemorrhage, even death. And yet their cultural tradition as very cultural Navajos was that sterilization was not acceptable. And so they didn't want to use any contraception and they continued to get pregnant. The last operative note from her 6th C-section was a little bit daunting in descriptions of all the scar tissue that had been encountered. And I was a first year attending, and I was alone. I didn't have any other obstetricians to back me up in that moment. But I knew what to do, and I wanted to prove myself. I felt confident in my surgical skill, and I knew what she needed. And so I gathered the team, and I started her C-section. But as soon as I entered the abdomen, I realized we had a problem. I could see her placenta growing through her uterus right over the serosal edge of where this incision should be to deliver her baby. She had something that we call placenta accreta. Her placenta had grown through the muscle layer of her uterus and was entangled in it. And in that scenario, a mother can bleed to death so fast when you try to cut through it because there's no mechanism the body has to stop that bleeding when it has invaded through the muscular layer of the uterus. I took a big deep breath. I'm in the middle of nowhere in a hospital with limited resources, and I'm the surgeon in the room, and there isn't somebody coming for me. I began to mentally calculate how much blood is there in our blood bank. How am I going to save this woman? I can't just shriek and close this abdomen. I have to fix this. And so I began to take charge of the room, and I began to ask for more help, and I asked for more nurses to come, and I talked with the anesthesiologist about what we were facing, and we called the blood bank before I even started cutting into the uterus. And I asked them to call my colleague who lived almost an hour away and to tell him, listen, we're about to do this. I know I'm going to have to do a hysterectomy. I know we're going to have to fly more blood in, and I need you on your way now. And I started. And we delivered the baby quickly from an incision well above the placenta, so I didn't have to touch it. But unfortunately, still it began to bleed, and it went fast. And I started to feel really scared, right? Like, I've got to be able to do this fast enough so that she doesn't bleed to death before we get enough blood. We started transfusing. I was clamping, cutting, tying as fast as I possibly could. My assistants were my midwife I was backing up, and my surgical tech. Usually in a big university hospital, we do these surgeries with 5 to 10 surgeons in the room, and we have so many more resources. This was scary. This was me. I knew what to do, but I didn't have everything I needed. And I was praying, let me tell you. Underneath my mask, I was praying. I was continuing. I was going as fast as I could. And I actually was almost done with the hysterectomy by the time my colleague arrived. He got there so fast. I never saw him make that time before. And we finished the hysterectomy. We had poured units of blood in her, more than 10 units. But that was actually kind of low for a surgery like this. And she was alive and she was stable. And my fear started to diminish. Her blood counts were good. There was no signs of coagulopathy. We were giving plasma. We were giving factors. We were doing it. And we kept her intubated because there's so much risk with that much blood loss of swelling in the airway and of going into DIC. We knew we weren't out of the woods yet, but we had almost made it. And we transferred her to the ICU, still sedated, still vented, but stable. And in that moment, my fear had receded so much that I felt incredible relief. It wasn't to last very long. I went home, I slept for part of the call night, and I was on my way back into the hospital around 7 a.m. when I got the call. Dr. Kang, we're coding your patient. We've been coding your patient for almost 10 minutes. Are you close by? And the fear just, whoosh, what had happened? Why were they coding my patient? And when I arrived in the ICU, the critical care attendant gave me a quick rundown of what was going on. Chest compressions were in progress. They were pushing meds. There was a lot of activity in the room, like there always is in a code. And she said to me, listen, she's in PEA arrest. We don't have a shockable rhythm. We've done this, this, and this. We've gone like all the way through the ACLS algorithm. At this point, we're going to get an echo. We're going to we started looking to see if there was some sort of fluid collection around the heart. What was happening? And the tumult of confusion and fear was in the room. And all I could think about was, she has 7 babies. She has 7 babies. She cannot die. This cannot happen. And I jumped up on the bed and I took over compressions. And I will never forget the sound of her ribs under my hand and the sound of my ID on my lanyard jingling as I'm doing compressions. You know, you remember these things in those most traumatic experiences. And I was not going to give up. In concert with my critical care attending colleague, we kept pushing it. We were checking and checking and checking, and we were giving these rounds of medications. We tried things that we hadn't tried before, and finally we decided, the only thing that we could consider is that this has been caused by a big pulmonary embolism, maybe, and we could give a TPA. We could give a clot buster, and my critical care colleague looked at me and said, but you just did surgery less than 12 hours ago. And yep, that, after all this blood loss, could cause internal bleeding. But this was our Hail Mary. And I just looked at her and do it, push it. And so we pushed TPA. We were at 20 minutes. This is the point where in most reasonable codes, we say, we've lost them. But we couldn't let go. And we all knew, the whole team felt the weight of that. This is a mother of 7. She has a newborn baby and 6 other littles who count on her. this cannot be. And we kept coding her, but I knew, and I began to feel that dread and that overwhelming grief. I knew we were doing something futile. And so eventually I pulled back exhausted. Doing 1 or 2 minutes of CPR is exhausting. I probably did it off and on for 15 minutes. And finally, I pulled back from the bed and everyone looked at me and we all nodded. The nurses, some of them, started crying. We started detaching. Her husband, who had been watching from the corner by the door, that scream cry that happens. And I looked over him. It was rage and grief all at the same time in his face. And he just started screaming. And he started coming at us. And nurses and security came running to grab him, hold him. They ushered him out. We're still trying to clean up all the equipment. This is that phase after a code where everyone's numb and in shock. And from the door, one of the nurses said, "Dr. Kang, you need to talk to him." And we've all done this. We've had to walk out of the room of a failed code. And we are carrying our own fear and our own grief and our own trauma. And we have to go and we have to prioritize the grief and the trauma of the family members. And this was kind of a scary big guy, too. They had calmed him in another room. I had to go talk to him. I had to go into his room and face him and say, "I am so sorry. We did everything that we could. We don't know exactly why she coded. And we couldn't fix it. I am so sorry. Your wife has died." And that was one of the hardest moments of my life. And I was scared in that moment, not just because it was so uncomfortable, because I'd never had to face this particular situation before, a young mom. We talked about it, in training. This was the goal, is to reduce maternal mortality. This is why we do what we do. This is why we've developed all these interventions. And we're succeeding in biomedical science. But it was a number, it was a theory, it was an idea, this maternal mortality. But it was happening right in front of me to a patient of mine. I was so devastated, I can't even begin to tell you the delirium that I felt like I walked in. And I went and I sat down at the nurse's station. And the beauty of our teams, right? They gather around. Nobody says much except, "You did everything you can. There's nothing you could have done. You're such a good doctor." All the things that we know we need to tell each other in that moment, because we know, we've been there. We know what's going through your heart and your mind at that moment. I had to walk out past the little kids, the 6 of them were sitting outside the hospital with their auntie. And they were sitting there. The older ones were crying. I had to walk past them to leave the hospital. Healthcare professionals, I'm so excited to be able to connect with you on issues regarding spiritual needs in healthcare. We want to partner together to see some of the ruined places of healthcare culture restored by hope. Follow us at restorehealthcareproject.org and like and subscribe to our YouTube channel and social media. Worst thing I ever have done. And I was a young mother. I had 3 little girls at the time. I walked back across the hospital parking lot to my housing compound that I stayed in. And there was my 9-month-old, my youngest. There were my little girls running around, happy. They had a mother. It just, the injustice of it, the cruelty of it felt unbearable. And I thought I was going to quit. My colleagues were the best to me during that time. I was just a young attending. They'd seen some of this before. They knew what it was. And they just came to be with me. My colleague, I'll never forget, she came into my house and she said, "You're not working this week. We're going to bring you meals." And she just sat with me, and she hardly said anything. She just sat with me. And then I would say, I'm not going to do this. I can't do this. I can't. I picked the wrong career, at least picked the wrong specialty. I can't do this. I can't bear this. This is awful. I know that everyone says I didn't do anything wrong. I know that everyone says I didn't fail, but I feel like I failed massively. Like, tell that to her kids. We actually have good reasons to fear in healthcare. So when I talk about fear in healthcare workers and how it's harmful to us and it's harmful to our patients, I want you to understand that I know that it's reasonable to be afraid. We stare death and dying in the face every day, and sometimes in really cruel ways. And we try to say no to it. And we win a lot of those times. And so when we don't win, it can feel absolutely devastating. And the human inclination to avoid that kind of that desolate pain is real. And we develop fear to try to manage that. We protect ourselves in fear because we don't want to go through that again. We don't want others to go through that again. And unfortunately, our society is very eager to blame us when an outcome doesn't go the way everyone hopes. And they want to hold us accountable. We always want to find somebody to blame for the grief that we're enduring. And so it's not completely unreasonable that fear has worked its way into our healthcare culture and that these kind of experiences influence the way that we think and influence the fear that we have that we might inadvertently convey to patients. But fear is hurting us. I think that certainly we can say fear can be a normal response to all these things we're experiencing. It can be normal to have fear when you've experienced loss and pain and accusation and failure and maybe shame. Maybe your colleagues shame you because maybe you could have done something different to avoid the pain and the loss. We are afraid of disapproval. We're afraid of loss of control because we can't control everything despite our best efforts. Isn't that true? The culture in healthcare, unfortunately, I have watched it, even over the course of my 15-year career, slide more and more toward creating a structure to avoid all of these things, to avoid pain. And our culture is doing it around us as well. We will do anything to try to avoid pain. And in healthcare culture, we've developed guidelines and policies to try to avoid these outcomes. They're very complex. They're burdensome. We have risk management whole departments that try to reduce the risk of legal actions based on bad outcomes. And they coach us and we have to document, and it's all very, very stressful. We have a culture of consent that is also complex and onerous. We have these lengthy consent forms that tell a patient how that basically anything bad that is known to man could happen to them from the thing that we're about to do. Like, wow, and we have to do this. This is called informed consent. We have excessive monitoring and documentation and testing. Why? Because we're trying to avoid that bad outcome, and we're trying to prove that we did everything that we could because we're also afraid of liability. It's traumatic to doctors and nurses to be accused of negligence, especially when most of the time they thought they were doing everything they could. So have we actually begun to create a culture around fear, so that we are trying to protect all the things that we are afraid of? And that is starting to become more prominent than the hope that we have for a good outcome. I recently was contemplating with my partner in practice the possibility that when we are counseling patients on health decisions, we might be using fear to manipulate them. And we confess to each other, although we definitely don't agree with manipulating patients, and we definitely support the idea of patient autonomy and individual preference and value in decision-making. We do think we often do know what is the safer treatment course for them. And we want so badly for them to choose that. And it's all well-intentioned, but we might emphasize risk and de-emphasize potential benefit in order to create a narrative that influences them to make what we think is the right decision. And are we violating their autonomy by doing that? And who are we treating then? Are we treating our fear? We actually need to be really honest with ourselves and look at it. I think our consent forms totally, they tell this story. Our consent forms list everything that we're afraid of could happen. I learned in Navajo about this in a really incredible way. You always learn your best things from patients. In Navajo culture, they did not want to be informed of all the risks because they believed that when you spoke out those risks, your words had spiritual power and they could make it happen. And so when I first started my job, my colleagues kind of sat me down and said, okay, so here, there's a different culturally sensitive way about consenting patients for procedures and surgeries, and you just need to know it. It's just different. Like you can't talk through a consent form with them. And the way we've gotten around this, because we have to somehow fulfill the legal requirements for informed consent from the hospital, is that we have a form and we tell them they don't need to read it, but they need to sign it, and we'll talk them through what's there. And we create this nebulous third person, not them. So there are some people, when they have this surgery, might have blah, 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 blah. But obviously for you, we have great hope that you will do really well. So at first that felt really dishonest to me. I'm like, we're not telling them the truth about risk. But in their culture, that's what they would require. And our patients would actually get up and leave and reject their surgeon if you began to speak about risk. And I think there was a little bit of, from the American cultural standpoint, that's kind of weird, but we'll honor it. But I really took it to heart. I was like, you know what? That is actually really interesting, that there's such value placed in the spiritual power of words that they would push back on our healthcare culture of risk and benefit and informed consent. And I really learned from that. I think we also have fear not only based on our personal experience, but we also have fear based on urban legend. So there's actually generational fear in healthcare that's been passed on to us. And you know this is true. You've been on rounds where the residents are being lectured by the attending about all the things that they have to do to make sure that this doesn't happen because they've seen blah, 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 blah. And that fear gets transferred. And then you begin to believe, I have to structure my practice. I have to document this way because of this and this and this threat that I have vicariously experienced through instruction. Some of us actually behave like our patients are the threat. That somehow we have to protect ourselves from the patients. And you know what? There's some reason for that. It's not completely unreasonable. There are patients who sue doctors claiming that they were not properly educated on the risks of not following treatment guidelines, and they win, and it devastates doctors. Like, you didn't follow my treatment recommendations, the bad thing happened, and now you're suing me for it. Well, if I had properly known, if I had been properly educated, I would have made a different decision. If I had really known what could happen. Is there a mantra in our sphere that the most effective way to motivate health professionals to do the right thing is fear? Do we believe that patients are best motivated to follow treatment plans by fear? Could there be a different way? I just want to take a moment to say this very clearly. I do not believe that fear is the best motivator. It should not be so. Heaven does not look like this. Fear is not the supervisor of heaven. And I believe that I am here carrying the life of heaven within me by the Holy Spirit. And that I get to bring a sample of what the culture of heaven looks like. And fear is not a supervisor there. Fear doesn't have to be a supervisor in healthcare either. We don't have to answer to fear. We don't have to build and construct all of our protective pathways around fear and because of fear. But how do we step out of fear? It feels a little daunting. It feels like a monumental task. How do we deconstruct a whole culture that's in which fear is so embedded? It's institutionalized in our healthcare culture. Well, what if it's not that hard? What if we have assumed that there's so much complexity built in around this that we're not going to be able to take it down? But what if it's as simple as a movement of individuals who step out of it? What if it is actually easily passed on? What if it's incredibly infectious? What if these individuals decide to stop playing the game of fear and they start really looking at what is motivating me right now? Is hope motivating me, or is fear motivating me? How do we find the courage to rise above fear? I would say that the Bible is very clear what the antidote to fear is. Very clear throughout. The antidotes to fear are love and comfort, and they are found in Jesus. You ever tried to rationalize someone out of fear? My teenage daughters will sometimes have, an anxiety moment. And it's usually not completely rational. But far be it from me to convince them that it's not logical to feel what they're feeling. But you know what I can do? I can comfort them out of fear. I can tell them, okay, listen, I understand that you're feeling this. From your perspective, it makes sense that you're feeling this. That's what comfort is. I'm going to be with you. I'm going to give you time and space to feel what you're feeling, and I'm going to comfort it. That is the most effective way to drive out fear. That's love. Some of us, I would say, have residual fear because we've never been given the time or the space to grieve properly and be comforted. I am so grateful for the colleagues, the nurses, the physicians, the midwives who gathered around me when I lost my patient and who comforted me, who were willing to be with me. They were willing to give me space. They were willing to tell me it was reasonable to grieve. They didn't make me pull my pants back up and be tough. They're willing to let me grieve, and they were willing to give me comfort. It's the reason I stayed in medicine. I felt like I would leave, but their comfort and their love helped me move past that fear of getting back into it and seeing something like that happen again. They reminded me of my destiny. They reminded me of the purpose why I was in medicine. They kept telling me, you're here because these women and their families, they need you. We need you. Don't let fear keep you from all the good that you can do. 1 John 4:18 says, there is no fear in love, but perfect love casts out fear. And 1 Peter 5:7 says, cast all of your anxiety on him because he cares about you. There's this beautiful comfort that the Holy Spirit can bring to us. And we can have an exchange. We can actually give our fear to the Holy Spirit, and we can ask him to give us something in return. That's what relationship is. Relationship with Jesus through the Holy Spirit gives us access to the comfort and the love that we need to overcome, to get the courage to rise above fear, to not let fear determine the choices that make our future. And Holy Spirit will be with us. Isaiah 41:10 says, do not fear, I am with you. Do not be dismayed, for I am your God. I will strengthen you and I will help you. I will uphold you by my righteous right hand. Don't be afraid. I am with you. The reason you don't need to be afraid is I am with you. I will be with you. I will comfort you in what is reasonable to feel fear. And I will soothe your fears. I will comfort your fears. I will love you through them. I need us to remember, for the most part, our pain experiences, they're lying to us about our future. There's so much hope that we can still give away past that fear, past that pain. And we encounter it. I really feel that it is what our healthcare sphere needs to hear from us. Hey, there's a reasonable way out. There's a way to find courage to overcome fear. We don't have to live like this. We don't have to live separated from love by all the structures we create to protect ourselves from these fearful things. As long as some of us will believe this, what will it take? Just some of us. And I challenge you, find the courage to rise above in the love and the comfort of a relationship with the Holy Spirit. I'm Dr. Jennifer Kang, and this is the Restore Healthcare Project. Hey, Healthcare Tribe. I hope that you've been impacted by what I've been able to bring through this podcast. I also want you to know about some opportunities to give back through my nonprofit, Selah Health International. We work to support projects for women and children of vulnerable populations around the world. You can learn more and donate on our website, selahhealthinternational.org.